Namri Bukmak. Firstly, I'd like to acknowledge the small amount of Yolngu people here, but they hear from me every single day, so that's why they're not here, because they've already heard this story. I would like to also acknowledge my Miwatj team that are here, ex-colleagues, and now I'm their boss, so I get to boss them around. But also some key people. Bronwyn, who's our researcher, who was awesome at helping us put this together to make sure that we get the story out about health and social determinants of health. Firstly, I should acknowledge my mother's clan, whose land we are on today, or the Miwatj people. Sorry, Mum. And all Yolngu TOs in our region, but also I would like to acknowledge the Indigenous people that have come from afar to this wonderful place that I call home. Garma's theme this year is to look towards the future and to look ahead. Well, this is something that obviously is important to us in health as well. There are a number of, sorry, I can't read my own notes. What have I written? There are a number of key goals that are identified in our strategic plans that are about looking to the future. And the same goes for this organisation, Youth Indy Foundation, and for this forum. Health is one of the key goals for this forum and for our people.
I get a turn now. So Mel introduced me, Steve Rossingh. I'd pay my respects also to the Miwatj, whose country we're on, and so we thank them for their warm welcomes, but also thank them for their leadership that they've displayed in pretty much leading the national agenda on Indigenous affairs for such a long time. So I pay my respects to elders past, present and emerging. And as you'll hear a little bit later, the emerging leaders is really an important part of the work that Miwatj wants to do and setting up succession plans. If there are any DLUC council members still here, also pay respects to them. So this is just a little bit of an overview about Miwatj. But as Mel said, the theme of this conference is about the future, education, vitally important, economic development, vitally important. But if we don't have good health, we don't have much of a future. So it's critical that we have systems, organisations in place that are dedicated to improving the health of Yolngu people. At Miwatj, we have 6 key goals, which I won't read through in detail, but I think the first one is very instructive, and it sort of talks to the whole concept of community control. Our first goal is Yolngu-powered community health and wellbeing. We can't underestimate the importance of Yolngu-powered. If we deliver our services, and a little bit of the history of Miwatj is that we run primary health clinics. Most of those have been transitioned from government control to community control. If we take community control and then run our clinics in exactly the same way as they were run by government, in some ways we might as well give it back. We have to ensure that we have a point of difference, and I'll talk about that a little bit more in a moment. The rest of the stuff there on this list of the key goals is pretty much what you would expect, but leading to the final one of putting another lens over the importance of Yolngu-powered is building job pathways for Yolngu. The previous speaker spoke about the importance of having Yolngu pathways, employment pathways stratified across organisations, so in senior leadership positions. And it was made very clear for me on my day one in this role, which only started in February this year, is to ensure that there's a succession plan put in place and actioned in my role.
Can you go back to the previous slide?
I'll try.
So I just quickly wanted to touch on, I know you saw the map, but I think it's important to share the story of Miwatj because those people that you heard from before, like Damien Dirkra, but also a number of people, Jawa talked about, the economy and the drive. You've all been hearing about Yolngu power, particularly in this region. Miwatj Health is a product of those Yolngu leaders back in the 90s when ATSIC existed. So Miwatj is not something that was developed because someone down south told us to do. This was Yolngu driven. During the ATSIC days, Miwatj is one of the organizations, as well as Dimuru, who you heard from yesterday, that is still here and led by Yolngu for Yolngu people. So I just wanted to put that important fact with that map that you've seen up there. That's original demographics that you see up there. The people we cover are Yolngu people.
Thank you. So Miwatj Health is an Aboriginal community-controlled health organisation. We see Aboriginal control as a key plank in improving things moving forward. So I suppose the first question is, what is community control and what is community-controlled health? Well, I think what's really important is that the fact that Mel and I are sitting up here together is no accident. My inspiration for community control comes from my chair. She knows that, and we have a very close working relationship. It's community control is quite an interesting concept, and I've been talking to some of colleagues from the Australian Institute of Company Directors whilst I've been here. It's not really something that's well described. It's not something that, if you do it properly, is actually even consistent with some of our incorporating legislation. So that legislation, whether it be the ASIC legislation or the ORIC legislation, is not really fit for purpose for community-controlled organisations. But we're certainly committed to community control. So in our organisation, all voting directors are Yolngu. We take a holistic, healthy, social and emotional, physical and cultural wellbeing perspective to things. It's a very holistic approach. And we also, particularly in relation to some of the comments of previous speakers, healthy country is such an integral part of that. It's a very holistic approach. It's a whole of life view and includes the cyclical concept of life, death, life. As I alluded to before, it's a health service run by Yolngu now and into the future. So if we're going to have that into the future agenda, we need to have a program for developing the next generation of leaders. And I've obviously got an early bloomer sitting next to me. But what's also really important is that, and other speakers have touched on this, we need to integrate Yolngu approaches into our patient care model or into our business model. If we just have Yolngu just sitting on the side, an interpreter asked to interpret and come into a consulting room every now and then, or not paying any attention to Yolngu knowledge and practices or culture or approaches, then we just won't be getting it right. So we need to make sure the challenge with this Yolngu control is about full integration. And really that full integration is only going to happen if we have more and more Yolngu staff in the right jobs across the organisation. Just a quick example of why Aboriginal community control is much better. There's extensive research, and I did a lot of this research in my previous role as Director of the NT Treaty Commission. There's extensive research that proves that around the world, community control achieves, if it's done properly and genuinely, much better results in any area for Indigenous peoples. One study, a recent study, an external study conducted by the Nous Group for the Institute of Urban Indigenous Health, I thought I'd try and use an Australian example, and a recent one, saw that the Institute of Urban Indigenous Health over 10 years made massive improvements. It showed that there's a net benefit to society from their system of care of $1.43 for every dollar invested. And conservative modelling calculated $100 million in net benefit to the community since it was established. Now that's a massive benefit. There's an improvement in life expectancy. We talk about closing the gap, and the initial headline of closing the gap was trying to close the life expectancy gap. Well, it's made externally validated improvements. Small, but it's in the right direction. Women had significant better outcomes on key metrics, 3 times less likely, for example, to have preterm birth and low birth rates compared to the standard rate. And we know how important antenatal care is to life expectancy. Significant changes in clinical outcomes measures, including positive movement in blood pressure and weight, and a 20% increase in young Indigenous men attending. If we don't have culturally appropriate and culturally safe clinics that Aboriginal mob are comfortable to come to, and in this case Yolngu, then we're not getting past the first step. So we need to have a culturally safe and appropriate, and this showed that in a place even like South Queensland, where the Urban Indigenous Health Institute is, they had massive increases in attendance, which just then flowed on to health improvements. So one of our key messages, and we'd really ask you to reinforce in all of your spheres of influence, is that community control is the way to go, but governments certainly need to let go and let us undertake effective community control. And I'll just say one last thing. The embodiment for our organisation and most organisations is our board of directors. That's why all decision-making board of directors members are Yolngu. We're sitting up here together because we're showing the strength in that process.
So we gave you a bit of information about community control and what it means to us, but also how Yolngu see it. Now we're going to give you the story about our people. So you came here, you saw opening Bungul, you saw young men getting up and showcasing culture. You saw young women and old women sitting down and sharing milk curry this morning. You will see bands, you will see artwork, you'll see healing, you'll see and hear lots of successful stories. Health is not a successful story here. As you can see on the slideshow, 60%, not 60% of deaths of Indigenous Australians are avoidable. And that's captured during 2015 and 19. That's more than the population of the people that are here, the Indigenous people that are here right now, let alone our little community on the Gulf Peninsula. Some of those preventable diseases, chronic disease, diabetes is a big one, and it's getting lower and lower and lower. People were getting it maybe in their 40s. Non-Indigenous people probably get it later on, 50s or 60s. Our mob are getting it in their teenage years, probably less. And we still have suicide and self-inflicted that's a high percentage for us. Don't forget, we're only 2% of Australia's population, maybe 3 now, but still, that's a high population. Maybe rate for our population. So this is why we want to talk to you today about social determinants of health. This is the story that we want to give to you, and for those people that left because they thought we were just going to talk about healthy eating, exercise, and all those wonderful things that people think health is about. Not the actual work that health has about self-determination, about us being in control of how we do health, and not just acute walk-in, band-aid fix approach. The person as a whole being treated as a person from head to toe, mind, body, and spirit. That's what we want to talk to you about in the next couple of slides. So we talked about those statistics just to show you more about statistics. Chronic disease does really have a big impact on our people. And only a couple of days ago, I was talking, me and Steve were talking, and he said one young GP, actually his son, who's training now, he said, "Dad, if there's one chronic disease illness that I would tell you to try and prevent getting, it's diabetes." And that stuck with me because I can tell you most of my family have diabetes. It's preventable, and yet every second person that I call auntie, uncle, mom, sister, brother have diabetes. I won't talk about this much because it's too depressing, but you can see why this is an important topic and why we need to start here, why we need to ensure that we break the cycle. We are in control of health. This is something that if we don't fix it here, why are we running a health service? If we're not going to prevent diabetes, might as well shut our doors, because we're treating a problem, we're not treating the cause.
So one of the key messages that we want to give today is that, again, we need to take a holistic approach to health. And there's a really classic quote from Sir Michael Marmot, which has really resonated with Mel, and in one of our first conversations she related it to me. Why treat people and send them back to the conditions that made them sick? But that's what we do. Someone comes in with a cut, put a Band-Aid on them and set them back into exactly the same environment to get cut again. But that's what we do. So to make a sustainable difference, we need to do things differently. We are a primary health care service. Basically, our core business is running clinics. It's a nurse-led, doctor-supported model. But if we just keep doing that, sure, we're helping people in the short term, but we're not making any long-term difference. So we need to do things differently. We also need to be aware, we talk about closing the gap, and particularly in life expectancy, but quality of life is critical. So we can take steps to increase life expectancy, but if the quality of that life, especially in the latter stages, is pretty ordinary, we can do better than that. So we need to start looking at what caused illnesses in the first place. It's Mel's key message, and she's so right. So what we've got to do, and what Marmot tells us, is we need to improve the conditions in which people are born, grow, live, work and age. We need to tackle the inequitable distribution of power, money and resources. We need to measure and understand the problem, evaluate action, expand the knowledge base and develop the workforce. We need to do all these things. And one of the key starting points is looking at environmental health. That's going back to addressing the conditions that made someone sick. The health equation is very complicated and it's not easy, and it's got lots of moving parts. But if we don't look at the social determinants of health, if we don't start addressing those with a starting point of environmental health, then we won't be making a difference. So you probably all know what some of the components of environmental health are, but the quality of drinking water is vital. Sanitation and sewerage is vital. Washing hands is vital. So getting those public health messages about sanitary practices. Food preparation is vital. In remote communities, and even King Stingray have written a song about it, camp dogs. Animal management is very important. To be crass, if big mob of dogs are roaming around a community doing poo everywhere, and that poo is just left there, that creates health problems. And something pretty specific, I suppose, to Groot, but also to Yirrkala, sitting right on the edge of a bauxite mine, is air quality is very, very important. So if we don't start addressing those environmental health factors, we won't be making the differences that we need to make. And if we don't make those differences in health, there won't be much of a future, no matter how good education and employment is.
So we talk about health and we talked about acute health or primary health care, but really it's not one thing, it's many things. And again, like was discussed before in the previous panels, it's about organizations working together. So sometimes probably most of the time when you work in an organization, you see structures of, whatever it might be. You have separate parts of key like, I guess, KPIs that need to be managed or goals of the organization. We see our work as working across. So we might have, health and maternal, child health and all these other KPIs, but they all need to be working together. But that doesn't stop in health. That also extends to organizations working together. And that's something that I'd like to see improve, especially at a national level, when we have people saying they want to support us, but they go off and do their own work. They don't work with us. So that's something that needs to improve when we talk about collaboration and working together to improve health. So this is our key takeaway message for you. And we want you to continue to talk about this and think about how do we as Yolngu people get the help that we need to make our population and our Yolngu people better through working together. So this is our message that we want you to take away.
So thank you everyone for your attention. Just one last thing. Mel's already done it, but I'd like to do it as well. Thank our staff for the wonderful job that they do in very difficult circumstances, and particularly here at the Garma Festival, we're running a clinic. It's basically a pop-up clinic, but it's been very, very busy. Unending dedication from a group of staff led by Sarah Dugdale, but lots of volunteers and helpers in that process. And we've also had a big public health team presence in trying to get that Yakanarali message out there, no smoking message out there. So we've had a great team of staff working over a long weekend. Ma.
Thank you for the hard work that you are doing there. We're now going to hear from the beautiful Nadyezhda.
First of all, I would like to acknowledge the Miwatj people whose land we have gathered on today. I would also like to acknowledge the elders past, present and emerging. Northeast Arnhem Land is the home to the Yolngu people. Yolngu Mata, or the people's tongue, has approximately 48 different languages, which belongs to the Dua and Yirrkala people of the lands. 90% of Yolngu people don't speak English as a first language at home. A Yolngu child will most likely hear English for the first time at preschool. So imagine being a 4 or 5-year-old child going to school and being taught in a foreign language. You don't know what's expected of you, and you can't follow instructions because you don't know what's being said. Also, there is Aboriginal English spoken, so you may have heard the word deadly around. So Aboriginal English is when the word is spoken in English, but it has an Aboriginal meaning behind it. So deadly doesn't mean fatal or it's going to end one's life. It means it's really, really good. It's awesome. It has a wow factor behind it. So we tell health professionals, don't tell an Aboriginal patient that they have a deadly disease, because they may go home and say, oh, doc said it was deadly. It's all good, mate. So the most common factors with Aboriginal health is communication. And that's why I became an interpreter, so Yolngu people can access their basic human rights of speaking first language, those services that are provided to them. I used to work in child protection prior to becoming an interpreter. The child protection worker asked me to remove a child from Groote Island. I said, I don't speak Andaliakwa. I speak Jambarpungo, one of the languages of the Yolngu family of languages. And the child protection worker turned to me and said, well, speak to them in Creole. I said to them, this is what I'm going to tell you, what you literally just asked me to do. You've asked me to remove a child that speaks Chinese. I've told you I speak Japanese, but you've asked me to speak to them in Korean. That's 3 different languages. We don't understand each other. So I left child protection and I went to the Aboriginal Interpreter Service and became an interpreter. So the hierarchy of languages, so languages are made up of lexicon, syntax and discourse, simply just known as words, sentences and conversations. So why do you need an interpreter? I don't speak your language. I need the interpreter. I was at the Darwin local courts one day, and when I went to see the lawyer and the client together, the client said, I don't need an interpreter. That was the first thing she said. And the Naja lawyer stepped in and said, no, I've booked the interpreter for me, because I don't speak Yolngu Mata. I don't understand Yolngu Mata. The interpreter is for me. And then as we were walking into the courtroom, the client turned to me and said, look, I'm a teacher, I'm a school teacher. I have a bachelor in education. I teach English to my students back at Millinginby School. And I said to her respectfully, don't get me wrong, in that courtroom is Australian legal English. It's not the standard Australian English. The words have totally different meanings to them, to the English that you teach your students back at Millinginby School. But if you would like to hear your matter in English, reply in English, please do so. But anytime you need me, ask me to take over. That's what I am employed to do. So when we walk into the courtroom and her matter was called, the prosecutor got up and read the précis. And once the legal jargon came out, she turned to me and she was like, hurry up, tell me what she said. I don't understand. So I took over. The client pleaded to their charges, and then when we left the courtroom, she said, I'm so embarrassed. I said I was a school teacher with a Bachelor of Education, but you were right. The English I heard in that courtroom is not the English that I teach. It's not the English that I speak. I'm going to go back to Millinginby and advocate for more interpreters and get community members to request interpreters, not just wait on the professional to do that. So, language proficiency is a spectrum. People can have proficiency in some subject areas, but not in others. Like the school teacher, she knows the standard Australian English. She doesn't know the legal Australian English. Also, there's different registers and topics. You could go to a health job, but when consent forms come up and informed consent, it changes. It goes to the legal field. Professional interpreters, we are trained to do those legal jobs, to the health jobs, or whatever topics they may be. Also, context and stress affects a person's ability to communicate. They have left their communities, their people, everything that they're familiar with. They've been flown on care flight to Darwin to a hospital that they don't know, languages that they don't know. Machines are beeping, things are happening in the emergency department. People are stressed, got anxiety, they don't know what to do. Also, there's difficult areas of communication. Time can be difficult. Distances can be difficult. Measurements can be difficult. How do you get the exact location, the time, what's going on, things like that? How do you do a diagnosis of a person in a language that they're unfamiliar with? Also, kinship terms are different. Mother, father, auntie, uncle can be different. My mother's sister is my mother too. My dad's brother, he's my father too. So when we're saying mum and dad, who are we referring to? Our biological parents or their siblings? So I'll just give you a quick plain guide to English to help you change the way you speak to Aboriginal people who don't have English as a first language. So avoid passives, supply the actor. We need to know who's doing what, who's doing the action. So rather than saying you will be reimbursed, you could change that and say, supply the actor, patient travel will give you that money back. That's the plain English version of saying you will be reimbursed with supplying an actor to go with it. Avoid abstract nouns. Supply the actor, change the noun into a verb. During the consultation, you said could be changed to when the doctor asked you questions at the hospital, you said. Put things into chronological order. Don't start with the present and then talk about the past and then jump between past and present and future. Put cause before effect and be wary of because. So rather than saying you're going to be penalised for 3 days because you did not comply with your Centrelink reporting conditions, you could change that and say Centrelink has rules to follow. That is why Centrelink will be taking away your 3 days' pay because you did not follow the rules of Centrelink. Also, avoid negative questions. Rather than saying, didn't you pick up your prescription on Wednesday? Simply change it and say, did you pick up your prescription on Wednesday? A simple yes-no answer. You never went to see the doctor last week, did you? That could be changed to, did you see the doctor last week? Simple yes-no answer. Avoid hypotheticals. Be careful of if and or. Use maybe or might. The doctor says the swelling will subside and you can play football. You could change that to the doctor says when the swelling goes down, you can play football, but if the swelling does not go down, you cannot play football. Clarify the use and understanding of prepositions such as for, from, and on. So rather than saying this will happen on the 22nd of August, you can say this will start or begin on the 22nd of August. Rather than saying this will happen until the 22nd of August, you can say this will end or finish on the 22nd of August. Clearly flag topic changes. So rather than saying okay and so did you, you could change that to now I need to talk to you about something different. I need to talk to you about, and then change the subject. Define new words before you use them in a sentence. So rather than saying prior to the procedure, I need you to sign a consent form, you can change that and say, now I need to talk to you about something that is called a consent form. So you've changed the subject and you're introducing the new topic. A consent form is a paper that says you understand and you agree to the steps we are about to take regarding your health care before it happens. Also, you understand and agree that something could go wrong. So that concludes my little presentation. And I would like to thank each and every one of you for giving your precious time to listen to my presentation. And also, I just want to leave one quote before I finish. Understanding each other makes a difference.
Sure.